Welcome everybody, I'm Steve Holloway, Chief Executive Officer here at Signify Research, and fantastic to be joined by Aaron Hillman from ROI International, and also Vlad from our digital health team here to talk through some of the big questions and the big trends that we're seeing in the digital health ecosystem today. So we've got 5 questions we're going to run through. Very much an open debate, and we're keen to have some punchy opinions potentially if needed, because there's an awful lot going on in that space. But we're going to jump straight in with the first question, and this is going to be a bit of a group discussion around what do we believe are the 3 main technologies that will shape and change the next year in terms of digital health. And Vlad, I'm going to come to you first to kick us off.
Fantastic, thank you, Steve. So, in my view, those can be summarized in 3 separate acronyms.
Mm-hmm.
As you travel the floor of HIMSS, AI is everywhere. So I think it's one of those technologies, and it comes in many different forms, and we can dive deeper a little bit in a second in what different forms of AI we have. Second one, I would call it FHIR, but broadly for interoperability. So the open air standards, the FHIR, the OMOPs in Western Europe. And last, I will call it an acronym of RPM, remote patient monitoring, but really what I mean here is the virtual seating, the telehealth, as we're trying to move away from the acute care to more hospital at home. So I think, broadly speaking, those 3 technologies from my perspective are sort of the key ones going to the future to help shape the digital health landscape.
Okay. Aaron, agree?
I do agree with that. I think that's an astute observation. I also think there's probably a 4th, which is just the deep dark we don't know yet. AI has been moving, we've been talking about AI for 15 years now. It's been the buzzword on the HIMSS floor for at least that long. And really only in the past, let's call it 2 years, has there been any actual valid use of it in our clinical or operational settings. I think what comes next, even from ChatGPT to agentic AI, was 13 months.
Mm-hmm.
That's shockingly fast. So I'd say there's a 4th we don't even know yet. And that's going to happen before we even get to HIMSS in March of this 2026.
Yeah. So uncertainty, which is always an interesting thing as a market intelligence provider whose job is to try and forecast what's coming next. But Vlad, let's dive a little bit into your comment there around AI. To Aaron's point, AI is this huge unknown in terms of how it completely changes the dynamic of not just the healthcare technology space, but everyday life.
Yeah.
Can you talk us through a couple of the use cases in terms of AI adoption across digital health where you think, this is really kicking off, we're seeing, real change in terms of healthcare providers' approach to using AI, and maybe a couple of areas where you think it's maybe not happening quite as fast as the hype would assume?
Yeah, definitely. I think it's worthwhile as well breaking that down between different types of AI systems, right? Because it's not fair to put the machine learning together with the generative AI. So I think that's very important. And machine learning AI has been around for quite some time, with the sepsis prediction that we've seen in the past, population health management type solutions. But now the generative AI is the interesting bit, which actually enables us to unravel what's behind the data, to offer those insights in more detailed depth. Obviously, ambient listening is the key use case for AI right now, whereby you have a patient-provider conversation, the notes are generated, put it in a specialized format that you need, and after that, they can be sent off to the EHR, followed up with some systems which have been automated to do referrals or potentially placing orders for labs, imaging, etc. And I think that's really the next part where we'll be seeing the development within the sort of ambient listening / EHR ecosystems, is those AI systems enabling the next event to happen, and then having a bilateral communication once the lab results are done, pushing that notification back to the healthcare provider saying, hey, this is done, so you can trigger the following event. Where right now it's been a little bit siloed. You'd have automation with each individual piece that hasn't been put together in a nice, seamless workflow, as far as I can tell. Another area which we've obviously seen a lot of uptake is with the likes of ChatGPT, Open Evidence, Alzheimer, Wolters Kluwer's clinical decision support playing in sort of that huge field. And specifically for Open Evidence, I think it's been an interesting startup in essence, because it's taken away business from the dominant players within the field, which is Wolters Kluwer and Elsevier. I think, granted, their business model is interesting. The evaluation, it's a bit crazy. to say the least. Nevertheless, it seems to be working, and the provider adoption is at the highest there right now. So I think that's a very interesting space to see where they're going to go further. Will they add additional features to their platform, like they have done so in the past with the ambient listening technology, offering that one for free? What will be next for them? I'm very curious to see. Where generative AI, I think AI hasn't been doing that much, and we've covered that quite extensively at Signify Research. I think it's AI and medical imaging, although the technology has been for quite some time. This year's report, we're able to see that actually our forecasts and projections have been revised down based on the fact that the providers are not adopting the technology as fast as everyone would have thought back in 2017 and 2018. And so I think imaging will be really great to see generative AI and AI as well, traditional AI, being integrated into the workflow more mainstream. But currently it's at a very patchy, siloed phase between different healthcare providers, and it also really differs by geography, whether you are in the US or Western Europe. The adoption rates there are very different too.
Well, I think that last point you made, Vlad, is a really interesting one, right? Because technology is all well and good, but it only serves unless it can be actively used, right? And or is actively being used. Ambient is a great example where, from a technological perspective and a documentation perspective, it works really well now. It's adopted very widely across the US. To your point, though, how do you get that to move forward to the point where it's actually driving clinical decision support and making things more efficient for the provider systems? I think we're still a few steps away from that. The other one that I throw in the mix that's interesting is, where does computer vision come into play, right? So we're combining the microphones with the video cameras that are in almost every hospital room and hallway and storage room and everywhere else in a healthcare system. How do you take those and also apply it to drive operational efficiency, reducing waste in the surgical suite, documenting present on admission indicators, patient turns in the bed just to make sure they don't get bed sores, right? There's lots of different things that we can pile in there. Again, I think it comes back to a couple of different things, which are, one, just purely level of compute and how somebody stitched those things together. And two, whether or not anybody's comfortable with the tools actually doing that for them. And I think there's still a level of distrust there. You brought up imaging as a good example. Probably the first place we had real AI clinical decision support. There's still a lot of folks that are uncomfortable with that, whether it's because they think it's going to take their jobs, which I do not think. I think it is augmenting, not replacing. Or they're just simply uncomfortable with the computer doing the work for them. Maybe it's both, but I think there's a much deeper set of questions we have to ask before we say, how do we get to this next phase of what are we using these tools for?
Okay. So to kind of summarize then, are we suggesting there's an awful lot of change coming, but probably in the near term, it's going to be a lot more on the kind of operational back office side of things, certainly the unregulated world in terms of healthcare. And actually, there's quite a lot of thinking to do around how organizations, and particularly the delivery of care, needs to be more comfortable with terms of AI. So there's a lot of sort of clinical advocacy work to be done. There's a lot of, I guess, almost user education. I guess if you take that back to a very wide, open-ended phrase, but it feels very much to me there's almost a widening gap between the cutting edge of technology and actually the pace of healthcare organizations being able to adopt, implement, in an efficient way, have the resources, the infrastructure to do that, and actually play catch up to that leading edge. So would you say that's a fair?
I think that's right. I think the other gap, and actually, Vlad, you said this really well, the adoption in different regions is really important, but there's a twist to that. It's not just the different adoption rates in different regions. It's how do we regulate and manage responsibly the application and use of artificial intelligence, right? The UK AI Act, the EU AI Act, what was happening in the US, but it isn't right now in any meaningful way. We've all got to get on the same page with regards to how we regulatorily manage artificial intelligence and the associated tools and applications, because if there's not any uniformity, nobody can develop with uniformity, right? And therefore you are losing this ability to scale up with new tools, even if you have a brilliant idea, you can't do it everywhere, which means that certain places get better access, and there goes your equity, and it creates a bigger rift.
Yeah, and that's a really interesting point, because I think there is also a bit of a misguided view, maybe outside in, that there are a lot of solutions that technology providers are bringing to the market that are off the shelf to healthcare. And in reality, I think we all know, having seen these put into place, they are rarely off the shelf and plug and play. So, which leads us nicely on to our next question. So, in terms of the next question, then, and Aaron, I'm going to start with you on this one. What would you say are the key issues healthcare providers face in solving data silos in terms of health networks? And with that, what role do you think digital health or health tech vendors can play? Now, your role is to help providers and technology vendors work together. And you've had experience on both sides of the equation.
Yes.
So I'd love to hear your thoughts in terms of what do you think some of those key things are around sort of data silo reduction.
It's a big question.
Yeah.
So, we've been talking again about interoperability for a very long time. One would argue that we haven't necessarily found the silver bullet for that quagmire either. But I think that there's a couple of different things. We have now realized the ability to aggregate, normalize, and optimize data from a variety of different sources, which then allows you to actually use it for something of greater value beyond just its initial purpose. This is great. There's lots of companies out there that do this. There are a few that do this very well. And that becomes, in my opinion, an essential aspect of actually reducing this data silo conundrum to use data for greater good. I think the challenge is that not everybody has figured out what do you do with that data for greater good once you get access to this large pool of data. How do you visualize it? How do you use it meaningfully? What are the questions you actually want to ask yourself or about your healthcare system or about your patient population or community or wherever, depending the kind of organization you are. There are some healthcare organizations, both in the US and UK and Europe, that have figured out some of the math to this and are really leading the forefront and are showing that out in the global stage of how they're doing it. I think a command center is a really great option for this, but you move beyond just the operational and you combine your clinical data and you start looking at real patient outcomes, but also how it affects the bottom line of a healthcare system, because unfortunately, like it or not, healthcare is still a business. Yeah. To the second part of your question, Steve, there's never been a greater moment for healthcare solution providers, I'm lumping in advisories and services into that, to partner together to help healthcare systems. And I do believe this is a shift in how everybody thinks a little bit too, right? It's always been a little bit of a us and them.
Yeah.
I've been a patient, I've been on the provider side, and I've been on the vendor side. And I think it only behooves us to just sort of say, we got to go at this together.
Yeah.
We can do this together. We can serve each other together. We know what each of us is good at. Let's do those things and build a true partnership and not just have it be a transactional sort of relationship. And that's you can even see that change over the course of the past 15 years, migrating that way. And more I hear it from providers saying the same thing.
Yeah. Just as a quick follow-on to that, do you think that from a healthcare provider perspective, it's a focus in terms of de-risking the engagement? Or do you see it more that healthcare providers are really saying, look, we're trying to fix some really big challenges here. We can't just have a transactional plug-in piece of software. That is not going to do it. What we really need is a wider roadmap to change management across the organization and partners who can come in and go on that journey with us. Is that?
Yeah.
Because I hear kind of both camps when I'm talking to both healthcare providers and tech vendors. There's a de-risking element, which is we need somebody to blame who's big when it all goes wrong. And that's obviously the skeptics' view. But there's also, we are really trying to solve some big complex issues here, and we need solutions providers who are willing to kind of step up and go on that journey with us.
Yeah, so I'm going to change the term from de-risk to risk management.
Yeah.
And I say that because we all have risk in how we approach these. Yeah, whether we're the provider or the vendor. I think that shared risk is actually the real way. And by everybody getting their hats in the ring, or whatever the euphemism metaphor you want to use is, we actually sort of inherently hold hands as you go into this. And that creates that level of partnership and required trust. Now, I do think the one throat to choke thing is an interesting concept you brought up there, because it's a little scary being that one throat to choke, but I think healthcare systems and therefore healthcare leaders are a little tired of the old way where these big firms come in and say, got you, give us piles of money, we'll give you the right strategy, but then you still got to figure out how to go do it yourself.
Yeah.
Healthcare systems want doers. They want people that are going to give them the strategy, create it with them, not just hand it to them, and then help them actually go do the work. Because resources are actually the limiting factor these days. There's not enough money, there's not enough humans, there's not enough clinicians, there's not enough room. Those are the things they need help getting to, and some of that can be fixed. Some of it can't. You can't create more rooms instantly, but you can create more access to the care through digital means and through virtual.
Just to sort of, on that point, don't you think we're finding ourselves in a sort of catch-22 zone whereby we need to invest into technology to alleviate some of that stress, but at the same time, the healthcare providers are having thinner operational margins to invest into those technologies, creating this state of limbo of, I don't know what to do. So, hard question, I suppose. What would be the right steps to solve that issue, do you guys think?
Yeah, I think it's a really difficult one, because you've also got to remember that healthcare technology solution providers are often public companies. They're generally dealing with healthcare providers that operate on annual budget cycles or short budget cycles. So the ability to navigate those longer term agreements into more of a risk sharing model is very difficult. It's funny, I've sat on a few panels and suggested, both with vendor solution providers and on the other side, and mentioned risk sharing as the direction of travel. I think the industry should be really considering much more strongly. And the look of fear you see on both sides of the equation is because it's messy, it gets into the financial side as well. And I think that's really hard to do when you're under all these other pressures at the same time. So are there any, I guess, and there's both of you who've seen so far, any really sort of practical steps or more simple things that healthcare providers should be looking at, or technology vendors should be looking at, in terms of what can we do to at least start on that journey, as opposed to thinking of the end, which might be risk sharing and long-term partnerships? What's the one or two things you think they should definitely be doing now that really helps enable that?
I came across an organization, and I'm not going to name it right now because it does slip my mind, but essentially they said, if we're not going to offer you 1 million in savings based on our technology solutions, then you don't have to pay us anything at all. They're really putting on display how confident they are within their solution. So maybe something of that nature could help some health tech vendors have their technologies adopted by the providers.
Okay. I think that's a great answer. I think that the simplest is start small, right? I mean, you don't have to undertake implementing an EPR to show that you can do a shared risk model. Do something small, whether it's integrating a few pumps, or whether it's deploying a few microphones or a few videos, or setting up a small system, or testing in a single location versus the entire system at once. Prove the point. That's actually, it's a different way of saying what Vlad said, but it's not free. And the reason why I steer away from the free model is, for a healthcare solutions vendor, that often sort of eliminates some of the value you bring. And if anybody else hears you saying that you're going to do it for free, that can further limit your value. And while I'm absolutely concerned about the very slim to zero margins that healthcare systems are operating on today, solution providers also can't operate on $0. And many of these small companies that are developing the most innovative solutions have very little extra money lying around to prove the point. So they can do it a couple of times, but they can't do it everywhere. And so developing a more cost-effective shared risk model is an essential thing for these developing organizations too.
Good. And I think probably just a quick follow-on, a really interesting observation, just through some of the research we do with end-user providers, but also just hearing anecdotally through the vendor market, who we obviously speak to an awful lot, is I don't think healthcare providers also do enough in terms of setting the basic frameworks that they want to be operating in, or at least setting the bar in terms of this is our expectation of you as an organization, and here's the roadmap we want to go on in terms of that sort of change management delivery plan. I think it tends to be quite short term and very much we're fighting fires and we need help now, as opposed to kind of taking a little bit of a step back and looking at that longer term vision of saying, here's where we need to be in 5 years, 7 years, 10 years time. Now that's understandable in the world we live in, and particularly as AI comes in and an awful lot of change is coming. I think we can all agree on that. But at the same time, you still have to have some degree of long-term vision that helps you kind of bring people along that journey with you. And I think that's maybe where some of the healthcare providers' leadership maybe needs to step up a little bit and say, yeah, this is where we're going. And that helps set the groundwork and the foundation in terms of the ecosystem that comes together around it.
I think that's right. I'm going to be daring and sort of say, we're in the UK today.
Yeah.
We've had a lot of things recently that are sort of pushing people to be more strategic over a longer period of time. But I don't think it's been enough guidance, right? So each trust is still on its own to figure out what it's going to do, how it's going to do it, how it's going to ask for money, how it's going to sort who to use, how it's going to work together, who else around them they should partner with, right? You're seeing more and more of individual trusts building these ICBs, but not even just an ICB. They're just deciding to come together. And so it's really an interesting moment where I think they are trying to figure out how to do that. But each trust has a senior leadership team, and each senior leadership team wants to stay senior leadership. And so you've got to sort of figure out also how you take this plan, this big amorphous plan with huge amounts of money somewhere, and figure out how to use it meaningfully to drive action, right? Because the vendors can only respond to what is it you want us to do, right? We can help strategize, but even then, when there's no clear, here's what we want to get to, it's hard to strategize.
So on to the next question. And Vlad, I'm going to start with you on this one to kick us off. What do you think the biggest competitive influences are going to be in digital health over the next 2 years? And I guess the context for this is as AI kind of comes in at pace, as we've seen over the last couple of years, and also we've seen the growing influence, I guess, of big cloud hyperscalers, the importance of infrastructure providers, and also even, the cutting edge of technology really starting to play more of a role in terms of decision making and technology adoption. So I'm thinking companies like NVIDIA, starting to make much more of an influence in terms of that and being involved in, the discussion around how we solve some of these healthcare challenges. I'm really interested to get your thoughts in terms of how you see that competitive dynamic shaping out in the next couple of years.
Yeah, definitely. It's a really good question. I think big tech, as we know them, and additional companies, OpenAI and co, they are going to play an increasingly prominent role within the healthcare IT landscape, whether we like it or not. I think it's a big debate right now happening and online and offline in relation to OpenAI roles in clinical decision support. It's an unregulated tool that's being actively deployed by both patients and providers internally without right guardrails in place. And so that's something we have to be very mindful of, is that although guardrails should be in place, they're not there yet. And so we should be adapting as a field to those changes within the landscape. And so I think big tech will play an increasingly important role in provision of stack, but also at the application layer where they will enable healthcare providers and healthcare technology vendors deploy their own applications on top of the stack. And that's going to create probably few rifts within the market, because right now healthcare providers are able to utilize models like AWS Bedrock, for argument's sake, to deploy their own applications, bypassing the need to have third-party ISVs. So what do third-party ISVs need to do to sort of stay relevant? And they will really need to provide this additional value that we've been talking about a lot. I'm sure you guys seen the release from Epic's UGM announcement in relation to the ambient listening scribe. You saw a flood of posts on LinkedIn and in conversations as well, where essentially people are saying ambient listening is dead, simply because Epic just did with that one move. Nevertheless, the argument from my side would be, if you're a really strong AI native startup with fundamentally right technology in place that you're able to add on top of the value and able to quantify that measurable improvement, then you're going to be successful. Whereas if you're just offering one simple feature of the dictation piece, then obviously you're going to be gone. And so for the AI native startups, I think it's going to be really key to sort of provide the measurable outcomes that you can challenge the Epics and Cos of that world, saying, hey, we actually provide a better solution than the alternatives. And then the last piece, of course, is pharma. They have an increasingly important role to play. They have the money, they have the power, and they are interested in investing into the digital health technologies.
Well, I think the ambient's a great example. And I'm glad you touched on AWS for a second there as well. So I think cloud infrastructure is really going to be our next battlefield, right? There's been an obvious and long movement to cloud from a data perspective and even from a operational clinical data perspective. There's been recently a very strong push and actually cost-benefit incentive for healthcare systems to do that, where it actually finally has become cost-effective to start moving data actively rather than what I would call responsively. When I say responsively, what I mean is you buy a cloud-enabled solution, inherently your data now goes to the cloud versus saying, here's my cloud solution, it's AWS or Azure or Google, whatever your case may be. I'm going to actively push everything there. I'm going to start reducing my dependency on hard infrastructure, right? Because it's not cost effective anymore, both from a resource and a cost perspective. The reason why I say that's the next battlefield is we're still not through this phase of on-prem, hybrid, and total cloud. And cloud or AI is completely reliant on the power of cloud simply because of the power of compute there, right? And so the infrastructure around our world to make cloud enabled at the pace and speed to actually provide opportunity to use clinically relevant data is not everywhere. It's getting there, but it's still not everywhere. And so for us to have what I'd call universal access to data wherever we need it, whenever we need it, it's also reliant on that. And so I think there's a very quiet battle stirring between the biggest cloud providers and who's going to get the most healthcare systems. Now, it's also very interesting, because you brought up Epic, I won't leave that one behind. I think it is very interesting which major EPRs will side with which major cloud providers, because there are lines being drawn. They'll say we can do it on whatever cloud you want because that's true and prudent. But there are definitely feelings about that out there. They have opinions, they have alignments, and again, going back to one of my first statements today, I think there's one or two we haven't seen yet. And they're probably not coming out of America, UK, or Western Europe. And it's going to be interesting to see how they come and provide cheaper, better, faster access to data.
Yeah. I always think what's really interesting in this debate also is how we jump almost to everything in the cloud. And actually we overlook the real pain of getting everything there, and also ensuring that what we're putting there is really valuable, well curated, structured data that is actually useful.
Yes.
And one of the things I think we've done loads of work in terms of talking to both again, on the buyer side in terms of understanding, particularly around cloud adoption, because it's a big trend across all the industries we cover, really understanding what the pain points are for healthcare providers. And so many times what is overlooked is, have we got the right network infrastructure to enable the capacity we need of moving that much data back and forth? Have we looked at egress charges enough? And I'm particularly thinking when you get into the clinical diagnostic realm and we're talking petabytes and petabytes of data, digital pathology, we're now talking about the genomics market really starting to heat up. Mm-hmm. And I just have this unerring question mark still of, are we talking about something that is really 2-3 steps down the line in terms of, healthcare providers really being in that position to say, yes, we've got this beautifully curated, cloud-enabled, ready for AI in terms of all of our clinical diagnostic and operational data. And actually, in reality, how quickly can we get there? Because if you're talking about you're in a big metro and you need to put a new infrastructure pipe in, that's a big, expensive job. And you're having to lobby local government and local infrastructure and network providers as well. So is it really that simple just to take that leap? Or should we actually be looking at this as a limiting factor or a consideration in terms of, well, actually hybrid might be the way forward for a considerable period of time while some of that infrastructure catches up?
Well, I think it has to be the way forward for a lot of the world.
Yeah.
But as you say, resource is everything. And if there's an organization or a region that has resource, or maybe is laying new infrastructure because it didn't exist before, then it changes the game. And I believe that people in general are smart enough in this moment to think about future-proofing as well, right? Mm-hmm. So if they're doing a big job like laying a new main pipe, they're going to do it big enough that it's going to be big enough for the next 20 or 30 years. I would hope. But again, it's that word resource, and distilling that word means 3 different things, right? It's the humans, it's the strategy, but it's the money. Yeah. It's expensive to lay infrastructure. It's not expensive to move data. Mm-hmm. I think to your other point, it's really just about what are we going to do with it when we get it there. But that is, I think, a different conversation.
I would just add, I think it's always going to be hybrid. I don't envision a situation where it's only going to be cloud or only going to be on-prem. Just for resiliency point of view, if there's going to be a natural disaster, you need to have some sort of backup, not rely on cloud too much. Another issue is the data sovereignty of the EU nations being reliant on the big tech providers from the United States. There's been a lot of sort of news from the big tech organizations of how they're trying to bypass that data sovereignty perception in the Europe. I know AWS has been doing a great job with their strategy there. But nevertheless, I don't envision a future yet where you're only going to be on cloud, because why would you want to put all your data on cloud? You're just going to skyrocket your expenses if you literally upload all of the healthcare providers' data on cloud. Not all of it needs to be there. If it's structured, well curated, and it drives insights, yes, absolutely. But if it's a healthcare record which is 20,000 pages, and 50% of it's repeated, same sort of allergies, same prescriptions, what's the point of having it all up there duplicated? And so we really need to streamline and only upload on cloud what's relevant for those AI workflows to really improve the healthcare outcomes.
Fantastic, great point. And I think ILM and that whole redundancy piece and risk, particularly in the world we're living in today, is also a huge challenge, I think, that some healthcare providers potentially overlook when they say, yes, we're going cloud. They forget about that part. So excellent point, Vlad. Thank you very much. So on to the next question. And this one gets a little deeper into, I guess, some of the topics we've just been talking about, but really digging into, I guess, the legals, the ethicals, and the real question mark around technology adoption. And that's around the regulatory approach to clinical and diagnostic adoption. Obviously, that's a really key thing around patient safety and ensuring that when we're bringing technology to the market, it is safe and it is right to use. But do we think, particularly in that kind of diagnostic and I guess the grey area of clinical, when we're getting into decision support and some of those sorts of things, there is some question marks, I guess, as in the industry around what negates. Is it software as a medical device? Does it not? To Vlad's point earlier around how some of the bigger generative AI companies are starting to kind of, I guess, test the boundaries of that in terms of their approach. But do we think that's always going to be a challenge for healthcare, and will healthcare always be a laggard in terms of tech adoption versus other sectors because of the regulatory burden they test to bear, rightfully so?
It's a great question. My shortest answer is yes.
Yeah.
We're constantly at the mercy of I'm going to be a little cheeky here, but I'm going to call it a regulatory fugue state.
Yep.
Right? We don't always know what we're doing. We can't always see through the mire. And everybody in different regions and even different organizations has different concepts of what is acceptable and what isn't. I think what the UK and the EU have done, in particular with the AI Act, is start to try to put some guidelines and boundaries around how it's developed, how it's applied, what the visibility of the tool should be, who can use what and where, and how frequently you're allowed to update based on patient data or developmental data that goes through the system. But it's not that well built out, right? I'm being extensive a little bit. In the US, we had a really, really great process that was aligned to what UK and EU were doing. But over the past couple of years, it's sort of broken down. And it's now actually being decided at a state-by-state level, which also, again, makes it more and more complicated. I think that from the perspective of an idealistic world, I would say everybody should get together and sort of decide how we are going to manage this responsibly and sustainably. And when I say sustainably, I don't just mean ecologically. I mean, how are we all going to better use AI and the tools that go along with it, including FHIR and interoperability standards and everything else that you need to get to that together? Because the truth is, you're not going to do it region by region because data moves, patients move, the pace of technology moves. We have to better enable these solution development organizations and humans to create a better together, for lack of a better way to say it. I know that sounds very kumbaya and very idealistic, I get it. But it's one of the few things that I think actually does require that level of shaking hands.
Completely agree. I think data standards harmonization, especially for software as medical device, is very important. But we've been seeing a rift between the US and Western Europe and the rest of the world in terms of how it's being approached, where the US is a lot more laid back in terms of the regulatory scrutiny right now. A lot more is allowed to happen there. Some of them are driven by the regulatory loopholes that they've created, like 21st Century Securities Act for clinical decision support type software that gives certain provisions, whereas in EU, we already had the shift from MDD to MDR, which has created certain issues for healthcare IT vendors trying to get regulatory approval and those bottlenecks. And now we're also going through the EU AI Act, which is also adding an extra layer of complexity around the topic. And I know a lot of large healthcare IT vendors who are saying we're not just doing business in Western Europe right now just because we don't understand what's going to be happening here on the regulatory front. And so I think that's a really big issue for the Western Europe as we seem to be falling behind the rest of the world. Asia Pacific is ahead in terms of data innovation. America is way ahead, and so something needs to be done. My bet is if the US is able to deploy their solutions, including foundation models and medical imaging, for argument's sake, if they're able to do it safely with their chilled out regulations, it's likely that Western Union, maybe in 5 to 10 years, will follow the suit, will tone down a little bit, just because they understand that not everyone can comply with the regulations that have been set in place, and perhaps maybe they were too harsh in the first place, and then provide some remedies to accelerate and enable us to catch up to the rest of the world.
Okay. Interesting.
If I could just play devil's advocate for a brief moment. So I agree with everything you said, Vlad. I also think that some of those chilled out regulations, as you say, and I'm going to use that, I love that, do create risk, because there's not quite enough oversight for some of the more, let's call them daring applications, especially in clinical application. And, in the end, the true responsibility of patient care still falls to the clinician.
Yeah.
But if the clinician is using a tool that the healthcare system has said we're going to implement, and the healthcare system implemented it because the solutions vendor said it's safe and here's our proof, but those chilled out regulations didn't force enough responsibility to provide enough proof, then we get into a patient safety issue. And we get into a resource safety issue, meaning the clinicians are no longer safe to practice care. And that's what scares me in that framework, right? So I'm not saying that it's wrong. I'm saying that a continued amount of scrutiny is warranted to ensure that these more daring applications that affect clinical care in an immediate way is required to be more thoughtful about how they continue to be deployed.
Absolutely, and I think just an observation more broadly, I do think we're probably moving in many markets towards more healthcare providers themselves having to self-regulate to a degree, and you might move away from a system that is very much centralized, nationalized in terms of FDA or CE mark or whatever, towards much more, particularly as AI and technology evolves quickly, you're going to have these very fast iterative changes in terms of the quality of output or what that product can do. So there's going to have to be a degree, I think, of kind of self-verification in there. A little bit like we saw during COVID with digital pathology and the lab approach there. But what I think is also really interesting there is you start to talk about the responsibility still lies with the clinician. That means we've got to win over clinicians from an advocacy point of view and an education point of view in terms of the adoption of these new technologies. And I think if you look at some of the success stories in terms of whether it's narrow AI or wider AI tools so far over the last 10, 15 years, they are generally companies that have gone really hard in terms of clinical evidence, but also really pummeling money into advocacy and adoption within that clinical group. And I think that's perhaps in a world, particularly in the last 5-10 years, where there's been a huge amount of venture capital and private equity money thrown at technology, it's often the missing step in terms of, well, you actually need to go and talk to the people who are responsible for delivering care to check they're okay with this. And it's maybe something that there needs to be a bit of a rebalancing in terms of thinking through what does this mean in terms of those on the front line who are doing this every day and ultimately the ones getting sued if something goes wrong.
Absolutely. Just to add on those points as well, I think it's a trend we've been seeing already, but it's only going to continue growing into the future, is the post-market surveillance. I think there's going to be a big shift away from focusing on the pre-market surveillance, evidence-based approach to seeing how the tools are actually being deployed. And I think it goes hand in hand with your argument, Aaron, in relation to that clinician needs to be aware of the technology and how good it's actually being at its job when it's being deployed. And I think this shift to post-market surveillance is inevitable. Organizations should probably invest in it already. If they're not doing so now, they should probably start today, because this is going to be a great proof of concept that your tool is working. It's going to give clinicians the reassurance to adopt it, improving the overall sort of adoption rates of the technology.
Okay, great. So to summarize, more clinician advocacy, a lot more focus, I think, by this in terms of a bit more togetherness, a bit more kumbaya, but at the same time making sure those parameters of safety retain all the way through, so there's clear direction and clear guidance to solution providers in terms of how they should be deploying this technology and where that line sits.
Yeah, I think that's all right.
Yeah.
One additional point there, we have to get even more efficient, because by asking providers to take on this additional responsibility, we have to take some responsibility off of them, because they're already doing too much.
Yeah.
Right? I mean, I'd argue not just the clinical providers, but when I say providers, I mean everybody that works in a healthcare delivery network. They're all doing too much. There aren't enough of them.
Yeah.
We've got to figure out how to take something off their plate if we're going to ask them to do this too.
So we've had some, I think, really interesting points digging into what I see as kind of some of the more subtle undercurrents maybe that we're seeing amongst the big marquee trends in digital health today. But we're going to open it out to a slightly more controversial question now, just to get the thoughts of the panel in terms of how we see this shift in terms of the health tech ecosystem changing. And I think we've touched on lots of these flavors, but we're going to put a big question out there. And the big question is, will EHRs exist in 2030? Who wants to go first?
I'm happy to dive in. I've spent the better part of my adult life working with and around EHRs, EPRs, whatever acronym you'd like to use. 2030, absolutely yes, they will still exist. I dare say they will continue to exist in digital perpetuity well beyond that, no matter what, in some capacity. They may not be where we do all of our work. They may not be where all of the data is captured. It may not force a nurse or a doctor to go and do their documentation every single time they speak to or see a patient. But for lack of a better way to say it, the patient record will live on. It has to, in some form or another. It may not require going into patient care manager and doing your documentation. That may happen automatically.
Yep.
But the record will exist for the next person to go and see what's transacted with that patient, see their history, and understand what needs to be done.
I
Agree,
would
disagree?
agree. Yeah, no, completely. Another acronym for electronic health records is CHR, as Epic has dubbed it at the GM, Comprehensive Health Record. Nevertheless, I think the role of EMR providers will continue to evolve as they are becoming sort of the guardianships of those data points, and perhaps their role will become from storing the data to orchestrating it and enabling AI to tap into those medical records that they're storing in a unified format, providing sort of the data layer that then they can orchestrate between the AI agents and other type of automation that we spoke about earlier today.
I think the other thing that is likely to happen, and this is a little bit Fahrenheit 451, Big Brother, what are we going to do about our future? But the biggest problem today for your average patient, and I'll use myself as an example, I had a minor injury a couple of weeks ago. I'm here in the UK. Getting care here was really hard as somebody that doesn't have an NHS number. I finally got care, fine. But getting that information from that care to go back to the US and see my primary care provider was a literal impossibility. And so then I'm forced to regurgitate the entire story multiple times to multiple care providers in order to just very simply get some meds. Shouldn't be that hard. I think where we're going to see continued rapid development, and let's call it modification of what the CHR is it becomes portable and personal. So I'm not suggesting we're all going to have little data pills in our arms, although maybe. But I think it becomes a much more easily transportable piece of data so that if I walk into any hospital in the world, I can say, here's my chip. And they will scan it and they can read it because it is uniform in data. Very simple, basic things that just let them see me as a human and a patient. And that's actually my hope, because even in the US or even here in the UK, you go trust to trust, system to system, that data doesn't exist, and getting it is impossible. As a patient, it's a nightmare.
So playing devil's advocate, what you're really kind of pushing for is almost a personal health vault.
Yes.
And I guess it comes down to a question of data ownership and the willingness, I guess, of 2 or 3 of the big kind of elephants in the room, being the EHR providers, the healthcare providers, even the pharma companies, who are itching to get at that data, or would argue, we've put all the systems in, we've put all of the infrastructure, we've spent all this money to create that data, why should you own it? And we're getting a little ethical here, but I think that there's a bit of a patient democratization movement going on at the moment.
Yes.
And particularly in the US, around taking back some of that control, and particularly around, as AI continues to ramp up, we're getting into how much do I want to give? And I think everyone is very aware of how much data they already give out into AI. Is there a question there where we're talking about very sensitive information and patient trust, where that actually might be the conduit for that to happen?
I mean, I think it's the right question. I don't know the right answer to it, but it's even happening here in the UK with the NHS Act too, right? I mean, say what you will or ask, your C-suite leaders of the trusts, they'll tell you the an NHS app is not the thing they want it to be yet. But I think that we're asking patients to take better control of their own care because that's what humans in general want, is more control over our own data, our own access, our own individuality. And that's at odds with this. We're giving more and more data. So I think it's an interesting dichotomy in how we create that balance. But by giving patients, they don't need to own the data. I don't think anybody wants to curate their own medical record. I certainly don't. But I think giving them access to a means to share it meaningfully and more simply will make them more comfortable in how they achieve care, how they comport their information, and how they translate it to actually get the care they need when they need it. It could be as simple as getting a script from Boots or getting surgery at one of the NHS trusts.
I always think a really interesting, and I completely agree, a really interesting parallel here is distributed ledger technology and the whole cryptocurrency approach in terms of finance. And I often look to finance and banking as 15, 20 years ahead in terms of technology adoption, but also in terms of the criticality of the information to the individual. Because finance information is probably right up there with health information as our most sort of confidential and important data. And I think what's really interesting, and not to get into the whole world of crypto, Bitcoin, and that side of things, and definitely no investment advice here either. I do think it's really interesting, though, that we're starting to see more focus and more discussion in some of those larger institutions around actually how this rolls out longer term, and how long does the traditional banking model stay the same. Now, if healthcare is 10, 15, 20 years behind, I probably agree, we're probably not talking about EHRs disappearing in 2030. It might be a little further along, but Vlad, we were talking just the other week about kind of the direction of travel with agentic AI, what that might mean. Maybe you want to summarize a little bit of kind of our discussion, but also some of the themes that came into it and a conclusion.
Yeah, I mean, there are many conclusions and many themes, but in a nutshell, essentially what we talked about is the role of agentic AI to coming and tapping into the data, and you don't need to have an application layer anymore. Essentially, you can just have an agentic layer, and it does all the visualization for you, all the dashboarding at the moment you sort of ask for it, taking away sort of those unnecessary 20,000 applications that you have to choose from. And it all seems hypothetically plausible, but obviously healthcare data is a little bit abstract. It's very messy and complicated. So how fast will we move there? It remains a question to be answered. Another point I want to add to that is there isn't only the generative AI with the insights, right? There is traditional machine learning that we spoke about earlier, AI and medical imaging. We kind of want to aggregate all of those different AIs under one big umbrella of an orchestration platform. And that orchestration platform should also be able to monitor, validate, and evaluate how well your AI is performing versus the real performance with real patients. And that's where I think the role of EMRs is likely to shift forward, essentially becoming the monitoring tools of different AI applications and agents being deployed throughout the care continuum.
I think that's a really interesting hypothesis. I think you're going to get a blend, but I do love the idea of agentic AI being the top layer. I don't know that you're ever going to get away from the 20,000 apps, although your average healthcare system is somewhere between 400 to 1,000, still too many. But orchestrating them together, great word, is, I think, the value that adds and streamlines efficacy and workflow and costs out and access to data in a more meaningful way.
Absolutely. And then you can, you talked about earlier the command center operations for utilization management that can all feed into that one big orchestration platform, enabling you to see sort of end-to-end workflow processes of the healthcare provider, and then straight away you can find which bottlenecks you can eliminate to get better return on investment.
That's right. 100%.
I think what's also going to be really interesting in this question, I love this question just because it opens up so many different streams. One of the things we're also talking about is where the tipping point is going to be, particularly with the pace of AI adoption on the operational back office side. And really, we're not necessarily talking about AI adoption, we're talking really about bringing autonomy into that setting. Healthcare providers complaining we haven't got enough resource. We're really struggling with actually kind of delivery of care just from an operational point of view. And is there a real role there actually that we should be doubling down on resources there and kind of worrying less about kind of the sort of front-end clinical diagnostic side and the agentic and the risk there, and kind of put that to one side for a while and really nail the operational side. Because if you can get healthcare providers being better in terms of managing their resources, their people, their kind of delivery of care from an operational perspective, does that then free up more time for driving better quality care in terms of the diagnostic clinical side, which obviously is more regulated, messier, more complex, more fragmented, and rightly so. So I don't know, is that something you see? Certainly I think the investors have backed that view in terms of where we've seen the inrush and some of those crazy valuations we were talking about before in terms of those companies that can provide that sort of technology to support the back office side of things. But do you think healthcare providers view it as a kind of segregated view, or do they see it very intrinsically baked and therefore you have to do both?
I don't want to speak for the healthcare providers. Yeah. My personal view is you can't push away the clinical side.
Yeah.
You just can't, right? Patients continue to need patient care, right? And clinicians continue to need help.
Yep.
That's it. They do. I think you have to figure out how to do both. The operational side really is a meaningful place to continue to develop. And from an AI perspective, it's slightly less risky, right? Because you're not generally affecting somebody's patient care outcome if you're changing some of the back office operational cost-oriented or fiscally oriented side of things. Redundancy and backup is really important in this case, right? Yeah. We still want to keep the data safe and secure and however you want to do it, whether it's on-prem or on cloud, fine. But you can make changes here using AI or agentic AI in ways that I think you can't do as aggressively on the patient care side. And so I think development here provides a proving ground for even some of the concepts of how we might change the way patient care is done using some of the same or similar tools. But I don't think you can do them in a vacuum or silo. I think they act as a single foundational element to how healthcare systems operate.
Great. Yeah, definitely. Okay. Yeah, it's an interesting point because one of the use cases I always go back to these sorts of scenarios, if you look at inventory management for cath labs, patient comes in, needs a critical intervention, you've left your AI system to order the right stents, the right tools you need for that procedure. You've got a high value team stood there, it hasn't ordered it, or it's got the order wrong. Yeah. What happens? Patient care is ultimately still severely impacted, particularly if you're looking at stroke or one of those other sort of real high pressure interventional short time care delivery challenges. And yet I think it's going to be really interesting as we go into the next couple of years of, I guess, more trust in AI, but more trust in autonomy as well. Are we going to be putting in place enough of those guide rails to make sure and de-risk that from happening? But I always have a few of these use cases in terms of mind of actually, well, back office really does impact the delivery of care. So I think you're right. We can't decouple it.
Yeah. I'm going to use a really old example that we've all just now taken for granted. For years and years and years, we've taken it for granted. But there was a time in the early to mid 2000s and even some places the early 2010s where every single vital signs automated recording had to be double checked by a nurse or a clinician. We don't do that anymore. They just go in and we assume it's fine.
Yeah.
On the very front end of that wasn't easy, right? Nobody fought getting vitals to drop into the right field in the right place at the right time every time it's done, and then alert somebody if it's wrong, or if it's bad, or if the patient's getting more sick. But we now just assume that works. I think we will get to a similar place with much of these developing tools or developed tools, but it just takes some time to get there and be confident in what the tools can provide, right? And this goes to the larger question that you asked, which is, will EHRs be here in 2030, 2040, and beyond? I think how that information is captured and used is the question, not will it be captured and used. It's how.
Totally agree. And one additional thing I'd like to add to the interesting example you were giving about patients sort of carrying their own healthcare data. It'd be great to see, but how feasible is it? Because I appreciate there is a bigger focus on consumer health now than ever has been before, but a lot of the data is sat with the provider that we're not able to change. So, for example, having spent some time speaking to a friend of mine who's been through the NHS, they wanted to change sort of their conversation that they had with the provider because the provider remembered it wrong, put it wrong in the system, and they couldn't manually go and override the conversation. They had to fill out a full formal application form to sort of go back and say, hey, actually, this was not part of our conversation, perhaps because the provider had 20 conversations and they mixed up which ones they were writing in which field. And so it then becomes sort of this issue of how can we give ownership of the data to the patient if currently they're not even able to amend anything in the fields.
Yeah. Well, it's a great point. And also some tools that we have already talked about today, like Ambient, could have resolved that problem for your friend that's been through the NHS. Yeah. Had Ambient been running and been capturing even just simple speech rec documentation, there wouldn't have been an error.
Yeah.
And so I think your point is spot on. We do have to be able to have input into how our care is documented, but the tools that healthcare providers use to document accurately also is relevant in that argument.
Fantastic. Well, I think we probably need to wrap up there because we are getting on for time. But just to kind of summarize, I think there's a huge amount of change coming. But in some ways, some things won't change at all. So we're sticking with the EHRs for a good while longer so they can breathe easy. But probably the two main points I've taken from this is healthcare providers have an awful lot on their plate at the moment, and really it's for solution providers and those in the ecosystem to really look at rebalancing that. So a little bit more can buy up. But also moving in a direction around ensuring that there's a lot of sort of clinical advocacy and when we're rolling out technology, it's really understood. Everybody in that Kumbaya campfire really understands their role and their approach, and actually is comfortable to a degree with the adoption of that new technology. And then ultimately that things are going to change, and maybe these organizations need to be looking at adaptability and really understanding, kind of moving away from that very brittle process base to a much longer term view in terms of how this fits into their vision and their longer term journey that we kind of all agreed is missing often from this discussion is very short termist. So fascinating discussion. Thank you very much for your time, Aaron, for joining us here at Signify HQ. But yeah, we will leave it there. Thank you very much.